So this is the day that I kind of just go over stuff with you guys, and you can sit back, relax. Um, for those of you who are not part of our residency, we talked about the learning pyramid, and the most effective way to learn is to sort of have some sort of an experiential approach where you feel and experience and get scared and all that kind of stuff. Just kind of listening passive, you don't learn as much. But, it's good to kind of get things from different perspectives. So you can the value of this is just kind of seeing how I look at things and do things, and you can kind of compare your ability to evaluate slides with what I do. So we got 10 cases. We'll kind of go through these. And again, we want this to be kind of somewhat boring. We start off with just always the same thing. What kind of biopsy are we dealing with? Is it inflammatory? Is it neoplastic? Is it maybe something other than that? If it's inflammatory, which pattern? If it's neoplastic, is it benign, malignant? What kind of differentiation? So just, you want to work through that every single time. It needs to just become like second nature, pretty much just like breathing. So if you're going to do dermatopathology, that's kind of what you need to do. And you don't necessarily, even if you're not going to make it a career, you still need to do that when you're approaching slides for your board examination. You don't want to have a problem on your board examination. The best outcome would be you go into the board examination, they look at the slides, and you feel like, why didn't they ask me harder stuff? You want to feel like you want to almost feel like they're insulting your intelligence by not making you struggle over these slides. That would be the best outcome you could possibly have. I remember when I took my boards years ago, I think they had like molluscum as like one of the second or third slides. And I thought, this is really an insult, to make me study and spend all that much time learning dermatopathology in my residency program. And they asked molluscum. And then the next slide was a hybridoma. So it was pretty interesting. And they had a CMV on there. So they actually had some interesting things on here. So anyway, here's a shave biopsy, and at low magnification, it looks pretty pale. The clinician probably thought they were dealing with a neoplasm. We don't really see much of a neoplastic process here. We just see something out here that looks pale. It almost looks at low power like maybe it's just a shave biopsy of something gray and pale, and maybe it was a zone of nodular solar elastosis. So maybe they thought it was a basal cell, it's kind of translucent, and they sampled it, and it wasn't a cancer. So it doesn't look like it's very inflammatory. Don't have any lymphocytes, no histiocytes, anything like that. As we go to higher magnification, we do see that this is not normal, this sort of grayish amorphous material here. And it is a deposit. So we have the two main categories, inflammatory and neoplastic. So always remember there's really a couple of other sort of mini subcategories. So deposits are sort of their own little separate category. We have hamartomas. Are those really neoplasms? No, they're not really neoplasms. Genetic abnormalities. So there's a few things that don't really fit perfectly within the categories of inflammatory neoplastic, but it's better to sort of at least keep it simple. Dr. Ackerman's second edition of his sort of world famous textbook, I think he sort of got a little bit too complicated, and he started making all these sub patterns and everything, and it never really caught on. The first gold edition of his textbook is really what really made him famous. So that's the textbook that I learned from, and that's the one that I still kind of use when we're teaching inflammatory skin diseases, because it has 9 patterns. It doesn't have 9 and 20 sub patterns. It's very simple, and that's kind of the way to best do it. So here we're looking at something that doesn't belong here. It's a deposit. And so when you're looking at a deposit, you need to ask yourself, well, what's the nature of that deposit? What color is it? Does it have, is it, and you got to sort of think in your mind what some of the main deposits are that we see in dermatology, in dermatopathology. Amyloid, we have colloid, we have exogenous things that are placed into the skin, like people that get injections of fillers, injections of collagen, Zyderm, those sorts of things. We can get, proteinaceous deposits, like in lipoid proteinosis. And then also ask yourself, where is the deposit? So, for example, macular amyloid likes to appear way the heck up in this area, right between the elongated epidermal rete. We don't see that here. We see something that's down in the lower part of the dermis. And we notice that the color of this it's got kind of a grayish blue color to it. So that's kind of important also. That means that it's most likely more of an acidic kind of process a little bit. It's not really, doesn't have a lot of DNA like up in here in these cells within the epidermis that are blue. But basically it's got this grayish color, so it probably was acidic in a way. So it's going to stain more blue. It's going to pull up the basic blue color that stains the acidic acids. And so it's might be an acid sort of substance. And then as you look at higher magnification, you can see that it's got these very fine little feathery, wispy crystals. Okay, I really want you to appreciate that. This is pathognomonic, essentially. There's only one other thing that can look even remotely like this. We really don't ever encounter that in dermatology. But this is pathognomonic for gout. When you see these little fine, wispy, feathery, whatever you want to call them, but you just imagine that, these are floating up in the sky like in a cloud. They're just sort of these little wispy crystals that you see here. And these are the gout crystals. And, they're so fine and they're so feathery that they sort of almost look like cotton candy when they kind of become a little homogeneous like you see over here. So this is gout. And we all know that gout is uric acid. So that's why it's staining kind of a bluish gray color like hyaluronic acid, as opposed to red, which would be something that would have a more base that would bring in eosin. It's more eosinophilic, for example. And one thing about gout that we sometimes see is it can sometimes get a granulomatous inflammatory infiltrate at the periphery of it. Got a few histiocytes here, so maybe it's trying to, host is trying to sort of wall it off and form a little, fort around the material. It hasn't really accomplished that just yet. And a couple of things we sometimes will see in gout is that we'll see some transepidermal elimination. So whenever you see something that looks white on the skin, maybe it looks like a little small pustule or something like that, you should at least say, well, is it also possible there could be something like calcium or gouty crystals or something like that that are being transepidermally eliminated through that in your differential diagnosis? And then obviously you're going to take a biopsy and lo and behold, you're going to see the nice gouty crystals here. Now, the other question that you may come up with is like, well, if you polarize this, would you see these crystals? Because there are crystals in here, but the answer is no, because the gout crystals themselves are soluble in water. And when this actually goes through the processing process, the tissue does, and obviously there are some changes where there is water involved there. And so the gout crystals get extracted. And so what you're really seeing is kind of the footprints, the residual little ghosts, if you will, of the crystals. And if you really want to actually see the crystals in the tissue, you have to preserve it in 100% ethanol. So it can't be exposed to water, and that keeps the crystals intact. And you can do polarization microscopy, and you'll see that nice little birefringence that's classic for gouty crystals. And they actually look brown if you do 100% ethanol staining. They don't look this sort of little cotton candy bluish gray color. They look more brown in the tissue. So this is gout. Gout tophi can occur in a lot of different locations. Occur in the classic locations of the toe. This lesion probably was on the ear. And that's actually not an uncommon location for this also. And clinically, there are little papules on the ear, and often they're misdiagnosed as a basal cell, and they get excited, a shaved biopsy like this, and clinicians usually surprised at the diagnosis. So that's gout. And that's fair game for the board examination. I said there's one other thing that kind of looked like gout. Oxalosis, interestingly enough. Histologically, the crystals look a lot like gout, but that almost never occurs in the skin. It's usually seen in the joint space, so you're not going to really encounter that. Okay, here we've got a punch biopsy from probably the trunk or the extremity. Classic location where we take most of our punch biopsies. And at low magnification, we say that it's most likely going to be an inflammatory process. We don't see any neoplastic cells in here. We don't see any aggregations of any abnormal, cells that shouldn't be here. So it's almost certainly going to be inflammatory. We notice also that it's pretty sparse, and it's mostly superficial perivascular dermatitis. So we've identified that at low magnification. That's the kind of the good news. The bad news is that this is probably the pattern that has got the most entities that can cause it. So there's lots and lots of things that can cause superficial perivascular dermatitis. So when you've got this pattern, you have to really have studied your dermatopathology, and you have to know which diseases can give you this pattern. Unfortunately, clinicians, especially in this era of electronic medical records that do the thinking for a lot of clinicians today, just will biopsy this and send it in as rash, or, rule out, drug eruption versus viral exanthem or something like that, that you really can't tell apart histologically. So you really need description, and you really need clinical correlation if you're going to make the diagnosis of superficial perivascular dermatitis accurately. If you're just, other than that, you're going to get back diagnoses of consistent with this, possible that, throw it back to the clinician. So you really need to spend a little bit of time describing what you see, and then we would look at this pattern and say, well, there's about 50 things that can give this pattern. But when you give a pattern of a widespread eruption that's got a Christmas tree distribution, that kind of lowers it down to about 1 or 2 things. So that can really be very, very helpful if we get those sort of things on the clinical information. So provide that to us when you're submitting biopsies. The good news for you is on a board examination, if they're going to show you something like this, they're most likely going to give you some information. So they're not going to be like it is in the real world, where we just get sketchy, sloppy material and information that we really need better information to make specific diagnoses, which is our goal. So superficial perivascular dermatitis, the cells are kind of dark and little jet black, so they're probably going to be lymphocytes. So once again, that's a very common pattern. And the next thing we ask ourselves, if we see this pattern, is there any sort of secondary change going on that can help us with the diagnosis? And we always look to the epidermis. So we're looking for epidermal reaction patterns. We're looking for parakeratosis. We're looking for spongiosis. We're looking to see if there's anything else in there. Is there ballooning degeneration? Is there epidermolytic hyperkeratosis? Is there acantholytic dyskeratosis? It might be seen with Grover's disease, which can also give you this pattern. So as we go to higher magnification, we see that the epidermis is a little acanthotic. It certainly is not massively psoriasiform epidermal hyperplasia like we would see, for example, in psoriasis. It's a little bit irregular acanthosis, but it's not strikingly psoriasiform. We also notice that there's some parakeratosis, and notice that it's in mounds. It's not diffuse over the broad front. So if it were diffuse and having neutrophils in here with this pattern, it might be Pityriasis lichenoides, which can give you that pattern. The Pityriasis lichenoides usually does not give you mounds of parakeratosis. So the pattern of the parakeratosis can be very, very helpful in the diagnosis of inflammatory skin diseases. Another condition, for example, that we see, we can look just at the cornified layer and suspect a diagnosis. Psoriasis, if you have mounds of parakeratosis with neutrophils above those, that's helpful. And then the checkerboard pattern of parakeratosis with Pityriasis rubinilaris. Basket weed cornified layer with spores and hyphae. Little slight, small wafer-like parakeratosis and ichthyosis. So, various diseases, you can look just at the cornified layer alone and come up with some differential diagnostic possibilities. So here we get the mounds of parakeratosis with some lymphocytes up here, no neutrophils, and slight amount of spongiosis. And as we go to even higher magnification, we see yet another clue, extravasated erythrocytes. So superficial perivascular lymphocytic infiltrate with these other changes, slight epidermal hyperplasia, slight spongiosis, mounds of parakeratosis with no neutrophils, some lymphocytes in there maybe, and then extravasated erythrocytes. Even in the absence of any good clinical information, the best diagnosis, putting all that together, would be Pityriasis Rosea. And then if the clinician was kind enough to have said this is a relatively acute eruption that developed in a young individual in the spring or the fall and is following classic Christmas tree type pattern, well, then you can make a specific diagnosis of definitive Pityriasis Rosea. If I saw something like this without much information, like rash, I would say consistent with Pityriasis Rosea. It really looks pretty good for that. And why would I just not say absolutely, positively 100% Pityriasis Rosea? Because theoretically a drug eruption could give you this pattern. You could see it in a viral exanthem. And why would a viral exanthem possibly look like this? Well, we know that Pityriasis Rosea is, we think, almost for sure, caused by HHV6. So it is a viral exanthem in a way. So when you get biopsies of viral exanthem versus PR or versus drug, well, the answer is sort of like, yes, it can be any of those. So it's not helpful to get just those kind of diagnoses as a differential, as information. We would like to have some description, maybe a clinical photograph, and then we can give a more specific diagnosis. And personally, it's better to get a specific diagnosis of PR than it is to say possible drug eruption. Then you don't have to go down a rabbit hole of looking at all the medications the patient may be taking and tell them to get off some medications that they may need. It's better if we can say, yes, this is PR. The clinical looks good for it. Histology looks good for it. You can counsel the patient, tell them it's going to go away in about 12 weeks, and they'll be very happy with you when it does go away. So that's why we like to get good information, because we like to make specific diagnoses. Now, what if you biopsied the Herald patch of Pityriasis Rosea? This is more the classic small plaque lesion that you see on the trunk or extremity in the Christmas tree distribution. But if you biopsy the Herald patch, it actually can look like a lymphocytic infiltrate. It can be a superficial and deep infiltrate that can look sort of like erythema, one of the gyrate erythemas, erythema annulation trifficum histologically. Usually has a little bit more spongiosis than that, but it can simulate one of the other figured erythemas. So it's probably better to stay away from that lesion unless you tell your dermatopathologist that you're biopsying the Herald patch and you suspect it's PR. Okay. Here we've got another punch biopsy of an inflammatory skin disease here. So we do the same thing. It's just boring. It's like, you ever see the movie Hoosiers before, and all the guys want to go out there and shoot the 3-pointers from the mid-court and all this kind of stuff, and Gene Hackman says, no, we're going to dribble, and we're going to do the lines, and we're going to pass, and we're going to do all this kind of stuff. We're not even going to shoot. And so he forces them to do the fundamentals. So that's what you need to do too when you're doing dermatopathology. You need to focus on the fundamentals. You want to go through this every single time. Biopsy, type of biopsy, location, all that sort of stuff. So punch biopsy, once again, from probably trunk or proximal extremity. Notice how different this looks than the last biopsy. It's a much denser infiltrate. And if you look at this side, it's maybe even going down a little bit deep. It's mostly superficial and mid, but it's kind of maybe trying to get a little bit deeper here. But certainly it's a lot denser than the last biopsy that we saw. And again, at low magnification, these cells look dark. They don't look pale like histiocytes. They don't look sort of salt and peppery like, it's a little bit harder to describe neutrophils at low magnification. But when they look jet black like this, you say, well, these are most likely going to be lymphocytes, most likely. And then we're going to go to higher magnification, we're going to confirm that. Is there anything else we can see at low magnification? Well, it doesn't look like, as opposed to the last case that had the nice mounds of perikeratosis, this has got a basket weave cornified layer on the top of it. So whenever you see basket weave cornified layer, it's not going to be crusted. If it's going to be got any scale at all, it's going to be super fine, branny type scale. It's not going to be, thick cornflake-like scale if it's got any scale at all. And usually it's going to have no scale. So it means that the epidermis really pretty much has not been involved. There's no spongiosis that leads to perikeratosis or crusting. There's no acantholytic disc keratosis. It's going to lead just kind of crusted sort of feel and appearance to it. So it generally means the epidermis is spare. So that changes your differential diagnosis already as well. So as we go to higher magnification, we're going to confirm that, yes, lo and behold, these are lymphocytes. There might be a couple of EOs scattered in here as well, but mostly lymphocytes in the infiltrate. There's no neutrophils or anything like that. And then we also see this other finding. We've got this pallor of the papillary dermis. And so when we see a superficial and usually deep, it could be deeper than this. We could have maybe a better example, but we don't see this disease that frequently. So we try to get one that at least correlates with clinical in this case. Superficial and deep lymphocytic infiltrate with papillodermal edema, you should think of one of the lymphocytic infiltrates, but then you start asking, well, what are the secondary changes that we see with lymphocytic infiltrates? And there's papillodermal edema, you think of polymorphous light eruption. And so this was a case that came in and had pretty good clinical history for polymorphous light eruption. And we said, well, yeah, this certainly is consistent with it. It's got the superficial and mid to deep infiltrate. It's got mostly lymphocytes in the infiltrate, and it's got the papillodermal edema. So we signed this out as most consistent with polymorphous light eruption. Now, that's a disease that also really needs clinical correlation. They want to have a good history of being photo-exacerbated, usually in the spring. It usually comes up at the beginning of the sun season, and then it kind of gradually goes away as the season gets more sunny. The patient's kind of hardened to it, if you will. So this is an example of one of the lymphocytic infiltrates that's got papillary dermal edema. Now, you might say, well, wait a minute, you've got some eosinophils in there. Isn't that not really supposed to be seen in polymorphous light eruption? In the classic forms, no, they really shouldn't have many eosinophils in there. But there are some other variants of polymorphous light eruption. There's the so-called papulovesicular variant, where you can get some epidermal involvement, and you can get some eosinophils in that subtype of it. So yeah, this wasn't the world's perfect example of it, but this is the type of thing that you should be looking for when you're making the diagnosis of PMLE. So lymphocytic infiltrate with papillodermal edema, without much epidermal change, without any cornified layer change, you should think of PMLE. If it's got lymphocytic infiltrate with mucin, think about the tumid form of lupus erythematosus. If it's got plasma cells, you want to think about Lyme disease or Starry. If it has nothing other than just the lymphocytic infiltrate, think about the possibility of Erythema gyratum repens, Erythema annulare centrifugum, and if it's the deep form of gyratum erythema, that can be perineoplastic. So you want to rule out any kind of underlying malignancy in that situation. And then there's a few other things that we could go into, but those are the main things that you want to look for when you're differentiating these lymphocytic infiltrates. So, if I were writing a board question and I would put this on there, I probably wouldn't just say the best diagnosis is blank. I would probably say, given these findings, out of these 4 or 5 choices, which is the best diagnosis? And you might list lupus and put that in there. That wouldn't be a very good choice, because you usually don't get papillary dermal edema, and you get mucin in lupus, which we don't see here. So that's how they might put something like this on the exam, or they might show you a picture of someone that's got a photosensitive eruption, and they show you this and ask you for the diagnosis. Okay. Take a look at this one. It's also an inflammatory process here. And we have our 9 main categories of inflammatory skin disease, and hopefully at low power right here, you can see right away that there is a subepidermal blister. So that's one of the 9 categories of inflammatory skin diseases, subepidermal blistering dermatitis. And when we're dealing with that, we ask ourselves, the first question is, if we really identify that it's truly subepidermal, what kind of cell is in the infiltrate? So this differential diagnosis is one that is fairly straightforward. There's not a gazillion diseases that give you classic subepidermal blistering diseases. So really separate them mostly by the type of inflammatory cell that's present, or if there's no inflammation. So if there is inflammation, we say, well, what kind of inflammations is it present? Is it neutrophils or eosinophils or a combination? That's the most common inflammatory infiltrates that we see in the subepidermal blistering diseases. We ask ourselves, what's the pattern of the inflammation? Is it more diffuse like here, or is it just kind of clustered, say, at the tips of dermal papillae, like you might see in dermatitis epidemiformis? We then, if it's got no inflammation at all, is it maybe perhaps epidermolysis bullosa acquisita? Is it one of the mechanobullous diseases? Is it porphyria? And sometimes PCT actually can sometimes give you some inflammation. You can actually get neutrophils in PCT on occasion. So that's kind of how we approach the subepidermal blistering diseases. And then, of course, you'll often be doing immunofluorescence on this. Another thing that you look for, too, in subepidermal blisters is whether the epidermis is necrotic or not. Most of the immunobullous diseases, DH, bullous pemphigoid, linear IgA bullous dermatosis, those sort of things, the blister occurs because there's an autoimmune process going on at the base of the epidermis here. It's not really attacking the keratinocytes. So it's affecting the basal membrane zone and in that area. So the epidermis floats away and it's not necrotic. If it's necrotic, you start saying, well, something is going on that's causing damage to the keratinocytes in addition to the blistering formation, and things like toxic epidermal necrolysis, Erythema multiforme, bullous fixed drug eruptions. Those almost always have epidermal necrosis overlying. PCT, because it's a phototoxic reaction in many ways, will give you the so-called caterpillar sign, where you see individually necrotic keratinocytes at the base of the epidermis. And here we don't really see much epidermal necrosis here. It looks like the epidermis just kind of floated off and hasn't really had nothing's really attacking it. It's a fairly recent blister. If you get a very old lesion of bullous disease, the epidermis can gradually die just because it's no longer connected to the base of the epidermis here, or the dermis. So you can just loses its nutrition and can gradually die. But most of the time when we biopsy vesicular dermatitis, we're biopsying a relatively acute lesion because the patient's developed the process and obviously got blisters, and dermatologists are concerned about it. So they biopsy this. They want to get a diagnosis. They can treat the patient with appropriate medications. So this does not have epidermal necrosis, and we're going to look at the inflammation. And notice here it's comprised primarily of neutrophils. There are a couple of eos here and there, but the vast majority of these are neutrophils. And the differential diagnosis of subepidermal blistering disease with neutrophils is relatively small. Dermatitis herpetiformis, linear IgA bullous dermatosis, the rare case of neutrophil-rich pemphigoid, which is really only diagnosed by using immunofluorescence and mapping and that sort of thing, because it really looks more like LIGA or DH. Some forms of epidermolysis bullosa acquisita can be neutrophil-rich. Cicatricial pemphigoid can sometimes be neutrophil-rich. So that's kind of it, really. Rarely you can get PCT with neutrophils, but here we would certainly think of this. And then the last thing I didn't mention, by the way, was bullous lupus can give you neutrophils when it's a patient that's got usually known lupus erythematosus, goes off their steroids, goes outside, and they think they're cured, and they get a massive flare of their lupus. They can get neutrophils in that as well. So subepidermal blister with polys, with this diffuse involvement here, probably the first thing that would come to mind would be linear IgA bullous dermatosis, especially if this were a kid. I don't really see much sun damage here, so it might actually be a younger individual. Obviously, you want to think about LIGA when you see this pattern, and you would do immunofluorescence studies to confirm the diagnosis. Obviously, in adults, make sure you realize that the most common cause of linear IgA bullous dermatosis is a drug-induced form that, even though it's induced by medication, it often does not have eosinophils in it, interestingly enough. You would sort of think, well, drug eruptions, eosinophils. Not always. And that's comprised mostly of polys. And obviously, the drug of most concern is vancomycin. But there are others, and make sure that you know other drugs that can cause linear IgA bullous dermatosis, because you're very likely to be asked that on the exam. They might ask, if they're going to ask about DH, they might get into some of the allergens, antigens that are associated with dermatitis herpetiformis, the gliadin and endomysial antibodies. They might get into HLE haplotypes. So make sure you understand and know some of those things before you take the exam. Okay, so we've got a lot of inflammatory skin diseases today, which is good, because that's something that you definitely need to know. And once again, here we've got a superficial perivascular dermatitis at low magnification with lymphocytes. So it's that same pattern that we saw a couple of slides ago, but this looks a little bit different. I mean, this does not have the nice mounds of perikeratosis like we had before. Something is different about this biopsy than before. So once again, it's got a long differential, but you've got to use some of these other items to help you make a specific diagnosis. And when you're looking at this, I always, even though, I always tell people that I always look at the cases without looking at the history first and then go back and look at the history after the fact. Today, it's almost not even worth looking at the history in a lot of cases because they don't give you any history. So you better get good at looking at slides without any history, because if you rely on the history from the clinician, you may be disappointed because it may not be anything more on the EMR generated rec slip than rash. Sometimes it's neoplasm uncertain behavior for everything, even though it's an inflammatory process. So you need to get good at just looking at it morphologically and sizing it up and making a differential diagnosis, and then hopefully being able to correlate it with clinical information that you receive. So again, it's mostly a lymphocytic infiltrate. And so we've got higher magnification here. This has got some very interesting findings in this. That's really super educational for you. Now notice it's got something going on in the cornified layer. And this is a very, very important and helpful clue to what you're looking at here. This is basket weave cornified layer. Now you might say, well, what's that? is that perikeratosis? What's going on there? That looks kind of weird. There's something there that is between the normal cornified layer and then this normal appearing epidermis down here. And what has happened here is that you had confluent epidermal necrosis. The epidermis is totally necrotic. We talked about that in the last slide, that with things like PCT and erythema multiforme and those kind of things, you get epidermal necrosis with vesiculation. Well, that's what happened here. The epidermis completely died. And then, this has been around a while, the epidermis came in and reepithelialized beneath it. And you've got this sandwich, if you will, of vascular cornified layer, dead epidermis, reepithelialized epidermis. So we see this in relatively few number of conditions where you get confluent epidermal necrosis like this with no abnormality of the cornified layer. This could not be a toxic reaction, for example. This wouldn't be like if somebody poured gasoline on their skin and got a secondary massive vesicular irritant dermatitis or a phytophotodermatitis, for example. That would give you alteration of the outer layer of the cornified layer here. So, and you don't see that. So this is normal. So clinically, you walk and see this patient, it might just look like a little kind of discolored area. It wouldn't really be crusted or scaly because it's still got a normal vascular cornified layer on top of it. And but it would probably look brownish because it's got these melanophages here in this dead epidermis that's sandwiched between the epidermis and the papillary dermis. And there are also melanophages down here as well, and mostly a lymphocytic infiltrate. So this is a nice example of the condition in the family of Erythema multiforme. Probably in this case, it was a bullous fixed drug eruption that then became reepithelialized because there are all these deeper melanophages here. If there's some EOs down here, that would really favor that because we get eosinophils in fixed drug eruption. I don't really see any here. So it's either EM that's reepithelialized, a later stage lesion of EM, or it could possibly be a fixed drug eruption. You've got one dyskeratotic keratinocyte here, so the process isn't totally dead. There's still perhaps a little bit of inflammation that may be causing this. And if it's a fixed drug eruption, maybe it developed, kind of went away. Patients may be still taking the drug, and maybe it's going to redevelop again at the site. So sometimes we even see like 2 or 3 epidermal necrosis areas that get reepithelialized beneath it. But it's a nice example of confluent epidermal necrosis with reepithelialization, and this it's developed at the site of something like the bullous fixed drug eruption or possibly erythema multiforme. Really not much else that will do this when you see this pattern. A little bit sophisticated. I don't think the board would show you this, but at least you know what it looks like. You've seen it, and when you encounter it in the real world, you'll know what you're looking at here. And I've seen well-trained, seasoned dermatopathologists miss this. I remember we were at a conference a few years ago, and the dermatopathologist presenting the case called it perikeratosis. He didn't really recognize this, but the patient had blisters, and they didn't draw the inference that this is the epidermal necrosis that was the eschar, if you will, that was between a reepithelialized epidermis here. So this was, once upon a time, it was a blister, and it isn't present anymore. So that's a great case, and it's a good educational case for you guys to understand that. Okay, another inflammatory process, and I would like you to appreciate here, in comparison to this case and the case of the PR and just the polymorphous light eruption, and even the erythema multiforme. Do you see at low power, these are not jet black? These are not jet black. Okay, so these are not all lymphocytes. So that I want you to at least notice that at low magnification immediately. So we're not dealing with the same differential that we were before. Okay, we don't know what we're dealing with just yet. It's okay, but you can right away. And I think it's valuable to do this because the quicker you can lower your differential diagnostic possibilities, the better. You don't have 20 minutes of slide on the exam. You've got, a couple of minutes. And so the faster you can narrow your differential diagnosis by using these clues that we're talking about here, the better it'll be for you. You'll feel more confident. You say, well, I can look at this isn't a lipstick infiltrate. I'm not even think about the lipstick infiltrate. Think about some other things here. You know, maybe these are going to be polys. And maybe they're neutrophils. So I'm going to think about things that cause neutrophilic inflammation, not that cause lymphocytic inflammation. You just wipe that out. There may be some eosinophils here, you know, so we don't know, but at least we know that we're not dealing with a lymphocytic infiltrate. And then you can kind of appreciate a low magnification. There's not a whole lot of epidermal involvement. This process is going on in the dermis, and this has almost got a Gren zone. You see how the papillary dermis is not really affected here? So that's helpful too. So it's not really attacking the epidermis. We're not going to be expecting to see a lot of spongiosis. We're not going to expect to see like epidermal necrosis like in the last case. We're going to just see changes mostly in the dermis here. Focus on that. And we're going to say, well, what could give you neutrophils in the dermis? It's not really diffuse pattern. It's kind of almost somewhat nodular. It's perivascular, but it's almost forming little small nodules here. It's certainly perivascular over here. So it's probably not sweets. That would be like a diffuse infiltrative neutrophils from this side to the side. But it does have the you know, a Gren zone, and there might be some papillary edema. So you might say, well, you know, we're going to not to completely throw that out. But at least we're going to be thinking about things more like that. As we go to higher magnification, you can see we were correct. There are polys here. There's a ton of them. And there are some eos in here as well. Okay. And if we look in this area, we also see some nuclear dust here. So nuclear dust. So when notice the epidermis is spared, which would be expected here. We see that there's a lot of this inflammation around some of these capillaries. We don't see any fibrin or thrombi in any of the blood vessels here. So we don't see that. But we do see an infiltrate mostly of neutrophils with some eosinophils, and we see this nuclear dust. So what is the diagnosis in this situation? Well, this is an example of relatively early evolving leukocytoclastic vasculitis. It's been around a little bit longer than most cases. If you biopsy a patient that's got a very tiny petechial lesion, maybe on day 1 or 2, the inflammation won't be this dense. And I'm kind of surprised, given the relative density of this, that we don't see any blood vessels that have fibrin. And there might be a couple of blood vessels here. There may be a little fibrin here. So you can kind of suspect LCV. If you're going to get an example of this on the board, they're going to show you probably one that's got really nice fibrin in the wall of the blood vessels or a thrombosed lumen with this kind of inflammation. But this is the type of inflammation that you see in leukocytoclastic vasculitis. Neutrophils, nuclear dust, variable amounts of eosinophils. So you're going to see this somewhere on the board, probably more than one time. And they might ask you second order questions about it. So they might say, okay, well, this is the best diagnosis. This is an example of leukocytoclastic vasculitis. Which diseases can be associated with? So they might give you some connective tissue diseases, maybe some infectious diseases, et cetera. So LCD, now, I'm not going to get into it at this time, the major differential diagnostic factors, but one thing to at least think about, if you get a lot of polys plus thrombosed vessels without a lot of leukocytoclasia, you should be thinking about infectious vasculitis, especially the gram-negative cocci, gonococcemia, meningococcemia, septic vasculitis. So septic vasculitis generally does not tend to give you as much leukocytoclasia because it's not an immune complex mediated process. It's not complement and antibodies that are causing the inflammation. It's usually due to the bacteria. And the gram-negative cocci like meningococcus and gonococcus are direct chemotactins for neutrophils. So they go in there, they plug up the blood vessels, get secondary thrombosis, and then you get all the neutrophils that come in, and usually that's you get pustular changes seen clinically, but you don't usually get leukocytoclasia. IgA-mediated vasculitis gives you a lot of neutrophils also. So this could very well have been an example of HSP that's causing this relatively early manifestation of LCV. So hopefully that was helpful to you, that you could appreciate the fact this is a completely different pattern than the ones we saw before with the lymphocytes. Okay. Now, again, I apologize because some of these are not the world's best example, but one of the reasons they're not the world's best example is a lot of these are relatively rare entities, so we don't really see this condition very frequently. But it shows a pattern that is helpful, and unfortunately, we got a a shave biopsy of an inflammatory skin condition. I'm not sure why. It could be that the clinician just doesn't do a lot of punches. It could be the location, because this disease also tends to occur on the ear. And, the ear's got cartilage there. And so clinicians generally don't do punch biopsies of the ear. They'll usually do a shave, even if it's an inflammatory process. So that could be the explanation for it. But anyway, we don't know the depth of it. So all we can talk about here is just what we see on the shave biopsy. And it looks like a relatively dense nodular infiltrate. And once again, if we're going to be betting on the type of cell, they're dark and they're black at low magnifications, they're almost certainly going to be lymphocytes. And notice that we've got some abnormality in the cornified layer, and also, well, I'm not sure the cornified layer, but certainly the epidermis here. We've got something going on in the epidermis. It's pale. And so whenever it's pale like that, we say, well, maybe there's a blister that's formed there. So we're going to go to higher magnification, take a look at that. But we've got a lymphocytic infiltrate with what looks like some kind of blistering process going on in the epidermis. Okay, so that's a relatively uncommon pattern. We don't see that too terribly frequently. Let's go to higher magnification and let's take a look at that epidermis. And notice here, we know that there are 3 ways of getting intraepidermal blistering. There is spongiosis, which is collection of fluid between keratinocytes, maybe a little bit of that here. And there's acantholysis, where the cells are falling apart. Don't see really any of that here. Maybe there's a couple of cells down here that are, but the vast majority of these cells are not. They haven't lost their adhesions to one another. And then the last one is ballooning degeneration. And here we do see inside these cells liquid. These are swollen. They shouldn't be this pale and filled with fluid here. So ballooning degeneration. Okay. Now, when you see ballooning degeneration, the first thing that you should think about is viral. Viral diseases very commonly, when they infect keratinocytes, cause ballooning degeneration. They can cause acantholysis, like herpes virus infection, HSV and zoster. There, the cells actually do get acantholytic. But if you're looking at things like a parapox virus infection, Coxsackie virus infection, those usually do not give you acantholysis. They just give you massive ballooning, and you can actually see intracellular inclusions. So we've got ballooning degeneration here. How'd the blister develop? Well, what happens is, just like any balloons, and your balloons filled with air, helium, whatever, they can pop. So when they fill up, they get swollen, they pop, and then you get all of this fluid that was once inside these cells collects and forms this blister. And you'll also sometimes see these little gossamer strands, like you see here. Here's some reepithelialization down here. But these are little gossamer strands, like the string of a kite, trying to hold the epidermis from floating away. And those are little residual collagen strands of the papillary dermis, and probably some cytoplasm, some cell membrane material of the keratinocytes. But think of it almost like, well, the dermis is trying to hold that epidermis and keep it from floating off into the atmosphere, like you see over here. So that's called reticular alteration. And it's classically seen with papillary dermal edema and also with ballooning degeneration, where there's vesiculation here. So the differential diagnosis of this would be a viral related process. Now, we look carefully, we don't really see any intracellular inclusions here. We just see ballooning. And then we also see this dense lymphocytic infiltrate. We don't see any neutrophils in there. And so this would be a disease where you really would need some clinical information. Okay, so they're going to, hopefully this wouldn't just come in as rash. They would say this is a relatively young individual that developed these blistering lesions on the ear in the summertime, in the springtime, early spring, and an individual that might be of Hispanic heritage. So the differential diagnosis, and when you see this pattern, putting this together, normally if you had a biopsy, we'd see a superficial deep infiltrate. This is an example of Hydroa Vacciniforme, which is another one of the intraepidermal ballooning vesicular dermatitides. It's associated with photo exacerbation. It's a photo disorder. And there's a group of diseases that give you this exact same pattern. Juvenile springtime eruption can give you this pattern. Hydroa Vacciniforme. So these are all conditions that are in the same general disease, if you will. And so basically just realize that this is one of the conditions. If you get a dense lymphocytic infiltrate on sun-damaged skin and you get ballooning degeneration and vesiculation, that's actually the most likely diagnosis. One other thing to remember here, this is a pearl, and I don't know if they'll ask you about this, but you should be aware of it. And then, sometimes they do like to ask esoteric things. This probably wouldn't be where they would expect you to recognize it histologically. But you can get a type of Epstein-Barr virus-associated T-cell lymphoma that's associated with Hydroa Vacciniforme-like change, and it also gives you blistering and this type of phenomenon. And that's a pretty aggressive form of T-cell lymphoma. It's a Hydroa Vacciniforme-like cutaneous T-cell lymphoma that's often associated with Epstein-Barr virus infection. So make sure you at least know of that condition. And if you were to see somebody that had this, you would want to exclude that. You don't want to miss that diagnosis because obviously it's more aggressive than other types of cutaneous T-cell lymphomas. It can be a pretty aggressive entity. Okay, so that's Hydroa Vacciniforme, juvenile springtime eruption, analogous type condition here. Okay, this different. We're now into the neoplastic processes, and we've got probably a deep saucerization here, and this part over here may be even an enucleation. So we might have an area where we have, maybe they did a shave of it, and they said, well, there's something deep to this, so let's see if we can go ahead and shell out the rest of it over in this area here. So when things enucleate, okay, that's a sign of benignity. It means that it was well circumscribed. It means it's usually, symmetrical, and it's not really something where you got tentacles of neoplastic cells intercalating between collagen bundles and kind of holding it into the skin. So if you do someone's got a little pilar tumor on their scalp, a little marble up there, you do a little incision on it, and you do a little dissecting around there, and you press on it, and it just pops out. Those are almost always benign. And a lot of these, they look like lipomas, they look like cysts clinically. So that's basically always going to favor a benign process when you see this. So again, is it inflammatory or neoplastic? Well, this time it's a neoplasm. Is it epithelial or non-epithelial? And even at low magnification here, we say that it's almost certainly epithelium. It's got this pink and blue kind of color to it. Here's the normal overlying epidermis. It kind of looks similar to that. So it's going to be epithelium. And when we talk about epithelium, then we say, well, what kind of epithelium is normally present in the skin? Not too many. There's stratified squamous epithelium that looks like the epidermis, like we have up here. There's follicular epithelium. There's sweat epithelium, sweat gland epithelium, both eccrine and apocrine. There's sebaceous gland epithelium. That's pretty much it. Okay. So the good news is when you have something like this is you can get it into an epithelial category pretty quickly. Now you have to know the subcomponents of each one of those epithelial structures. For example, if it's a hair follicle, is it the infundibular area? Is it the isthmic area? Is it the inferior portion of the follicle? Is it the mantle zone area? So you have to know which part of the follicle you're dealing with. For example, if it's a sebaceous gland, is it the duct? Is it the mature sebaceous elements? Is it the germinative sebaceous elements? So you have to know all of those various things to be able to accurately define what type of differentiation an epithelial structure is exhibiting. So we're not saying it comes from the follicle. We say it differentiates towards the follicle, towards this type of follicular epithelium. So here, as you go to higher magnification, it looks like a follicle. So which part of the follicle? Well, probably like the area of the isthmus and just maybe around the mantle zone kind of area there. So this looks like the trichilemmal portion of a hair follicle. Doesn't look like the infundibulum. It really looks more like that part of the hair follicle. And when we see trichilemmal differentiation, and here it almost looks like a little small cyst structure, it's most likely going to be a trichilemmal cyst. Now, this one's got a lot of aggregations. Mostly you see a trichilemmal cyst. It's one cyst lined with the trichilemmal epithelium like you see here. This is what looks like the trichilemmal sheath, the inferior the inner root sheath of the follicle, the outer root sheath of the follicle out here. So this is looking like that part of the hair follicle normally that's turned into a cyst. So this is a trichilemmal cyst, or a isthmic cyst is another thing that you could think of here, but this is a trichilemmal cyst, benign or pilar tumor. Now, when you see these lesions, this has got way too many of these aggregations. This is what we call a proliferating trichilemmal cyst, proliferating trichilemmal tumor, also known as a WEN, W-E-N. And one thing about these is sometimes they can undergo malignant degeneration. Now, an interesting sort of phenomenon is when you get malignant adnexal tumors, they almost always start off as benign. And if they're present for many, many years, they can sometimes undergo malignant degeneration. So when they do that, the architecture still looks benign. They can still pop out, but you start looking at it and saying, well, gosh, it's really pretty atypical over here. There's maybe a mitotic figure, and, you've got some really polymorphism over here. So you might say, well, you know what, this thing, even though it's overall benign, and, we got it out before it's really ever turned anything really super serious, it's probably got areas of carcinoma in situ arising within it. So basically a proliferating trichilemmal carcinoma, X proliferating trichilemmal tumor, benign process. We see that with pleomorphic adenoma, pleomorphic adenocarcinoma, X pleomorphic adenoma. They've used the word X, which means from. So basically that is where the lesion is developing within a pre-existing trichilemmal tumor. This is relatively rare. The vast majority of these are benign, not atypical, but they get overcalled as cancer because they see a few little atypical cells here and there, and then somebody says, oh my goodness, this thing is turning into cancer. This one has got more than the average bear, so we were concerned about this because it does have so many of the areas that are atypical and polymorphic. But the vast majority of these are just benign. You can remove them like this, they shell out, patient lives happily ever after. So beware of overdiagnosis of cancer within these. But when they do develop, and then this is kind of what happens in that situation. Okay. All right, we're going to shift back to inflammatory. And guess what? We've got that same pattern we've seen a couple other times today, haven't we? Superficial perivascular dermatitis with lymphocytes. So once again, you've got to use other features to make the diagnosis. This just comes in as rash, not otherwise specified. Highly unlikely to get a specific diagnosis. So this could be a drug eruption. This could be a lot of things. When I'm looking at low magnification, probably in a situation like this, the most common biopsy of an inflammatory skin disease that we see in an older individual that's got a dermatitis is going to be a drug eruption. And we see atopic dermatitis in older people. We see asteatotic dermatitis, that's still a cutaneous disorder of immune senescence. But patients come in, they got a widespread eruption, they don't feel good, see the dermatologist, they want to get a diagnosis, so they're biopsying something to diagnose a drug eruption. The good news about drug eruption is, if we see it in the context of clinical information, it looks like something like this, probably a more biliform eruption, nothing to worry about. The bad news is we may have a difficult time saying specifically what it is, and if it comes in with no history, it's very, very nonspecific. So you have to get information here. And so we're looking at high magnification. Again, drug eruptions don't have to have any eosinophils in them. They can, but they don't have to. And I don't really see too many here. It's mostly just a superficial perivascular lymphocytic infiltrate. There's not a lot of change in the epidermis. There's maybe a little bit of spongiosis. There is one EO here in that case. There's maybe a diskeratotic keratinocyte or two. So there's maybe a diskeratotic keratinocyte. And that's what we see with drug eruptions also. So this would be kind of a superficial perivascular dermatitis. That's most likely a drug eruption in the proper clinical context. If we didn't have any information at all, once again, we couldn't rule out a viral exanthem here. We couldn't possibly rule out asteatotic dermatitis or maybe even a subtle atopic dermatitis. The presence of the diskeratotic keratinocytes suggests drug eruption. And if there are a lot of diskeratotic keratinocytes and just on sun-damaged skin, it might be a drug eruption that's exacerbated by the light, such as maybe a thiazide diuretic. So it might be a phototoxic drug eruption if there are a lot of diskeratotic keratinocytes. So this is a very, very common reaction that we see in drug hypersensitivity. So don't expect when you do a biopsy of a drug eruption to get back a specific diagnosis that says something that this is a classic example of drug eruption, because this is really kind of what we see most of the time when they're more billiform. So it can look very much like a viral exanthem. It can look very nonspecific. It can look like persistent emitted preferred dermatitis on the legs. You can rule a lot of things out, but you really have to have good clinical correlation in a situation like this to make a definitive diagnosis. So it's a good example of what we see in drug eruptions. Notice that it doesn't have the nice parakeratosis of the extravasated erythrocytes that we saw with Pityriasis rosea, although you can get Pityriasis rosea-like drug eruptions. Gold is a common cause of that. It doesn't have the broad zone of parakeratosis like we might have seen with Pityriasis ligonoides. It doesn't have any acantholytic disc keratosis, doesn't have any other changes. So it's just relatively non-specific and in the proper setting, drug eruption. So they could possibly show you something like that on the exam. Okay, this last one we'll do really, really quickly. And the most important thing here is the epidermal reaction pattern. So it's a shaved biopsy, so we think we're probably a neoplastic process once again. And we can see that it's got an abnormal epidermal architecture here. It's too thick. It's got prominent hyperkeratosis. And as we go to higher magnification, this is one of those where you need to recognize the epidermal reaction pattern. Okay, so what are some of those? Well, there's acantholytic disc keratosis, which we see in Dariers and Grovers and several other conditions. There's spongiosis, which we see in contact nummular dermatitis, id reactions, those sort of things. There's this pattern, which is epidermolytic hyperkeratosis. Epidermolytic, the cells are kind of beginning to sort of lyse, and they're sort of degenerating. Hyperkeratosis, lots of that here. And within the cells themselves, you get this pink eosinophilic granules within the cytoplasm. Those are sort of bizarre, irregular keratohyalin granules. Okay, this is not corlicytic change, not corlicytosis. You don't usually get these pink eosinophilic keratohyalin granules in classic corlicytosis of a wart. So this is epidermolytic hyperkeratosis, and that's seen in a number of different conditions also. Epidermal nevi, and in this case, supposedly it was an epidermal nevus that they shaved. It can be seen in bullous congenital ichthyosiform erythroderma, which is also in the old days, we used to call it just epidermolytic hyperkeratosis. They can be solitary lesions. They can be widespread multiple epidermolytic acanthomas. So this is another situation where you need to know the reaction pattern and where these can be seen. So that's very important. This also can be seen in Tylosis palmaris et plantaris. This can be associated with the perineoplastic process. So there's just a number of conditions, and that's fair game for the board. They can show you something like this and say, this was a solitary lesion, the most likely diagnosis is, and they could even put on there epidermolytic hyperkeratosis, congenital bullous ichthyosiform erythroderma. They was solitary lesion, and you chose that. They both give you the same reaction pattern, so they're testing your knowledge as to whether you realize this can be seen in one of a number of different settings. So that's epidermolytic hyperkeratosis reaction pattern. Okay, hopefully this was helpful for you guys. I'll tell you about one other thing that's coming up if you're interested. We're going to be having a town hall Zoom call on October the 29th. I think it's going to be at 7 o'clock in the evening. It's basically going to be dealing with the issues related to reimbursement in dermatology and what we should do to counteract those. I did those kind of town hall meetings when I was president of the AAD a number of years ago, and they were very effective. And I said, well, we've got this issue that a lot of people are upset about, so we're going to have a town hall meeting that anyone can join. So if you're interested in doing that, we have it on our website. You can go there and you're welcome to join. We're going to probably go for a couple of hours. We're just going to take ideas, anything that people think about how to deal with this, write them down, collect it, put it together in some kind of a document, and see where it goes from there, and maybe submit it to Congress or to the AAD or something like that. So anyway, we'd welcome you guys to join that. And I hope you enjoyed the session this morning. I hope it was educational for you. And You're welcome to go back and review this again. We record all of these. So good luck, and we will see you next month.